So it's appropriate at this point, after we have excuse me, looked at the bones and the muscles, to begin to kind of put the skin back on the body and ask ourselves, what can we see from looking at someone kind of with the naked eye, with your skin on? And this would be what we call surface anatomy. So we're going to look at parts of bones and parts of muscles that you've already learned that we can actually see when we look at somebody kind of as they stand with their skin on. And so you'll learn a few new terms here, but largely you'll just be kind of rehashing the bones and the muscles that you've already talked about and you've already learned. Just make sure you add the few new terms that we'll learn along the way. And then at the end, we'll talk a little bit about cross-sectional anatomy, just what it looks like. Maybe if you're looking at a CT scan, for example, or an MRI, how you would identify parts of the body in those kinds of views. So let's start with the head and neck. So we'll kind of look at our regional look at surface anatomy, head and neck, and then upper arm and lower arm and chest and trunk and so on. So we'll start with head and neck. And again, a lot of these are things that you've already learned, but we're just going to see them with the skin on. So the cheekbone here, for example, that's the zygomatic bone, and you guys have already learned that. We learned about the external acoustic meatus and the internal acoustic meatus, and those are holes, which sound and nerves travel through in order to get sound waves from the atmosphere into an electrical signal to your brain. But there is also what we would consider to be our ear, or our external ear, and we would call that the auricle. So the auricle is basically the flap of cartilage and skin that hangs off your head that most of us would call the ear. Mental protuberance, you've already seen. The body of the mandible, right here, it forms the majority of the jaw with the angle occurring here, and the ramus up here. So you've already seen some of those. Trapezius muscle is this big muscle here on both sides. The clavicle you can see sticking out there as well. The sternum, of course, is the breastbone, which you were probably already familiar with. There are a couple of things that you can see here on the neck that we haven't learned yet. We will talk about them when we get into the respiratory system, but I'll mention them now, and you should learn them now. They'll help you when you get to the respiratory system if you've already learned them. And these are two types of cartilage that occur in the anterior part of the neck and are both part of the trachea, or I should say the larynx and the trachea. So you have the thyroid cartilage. That's the easiest one to identify. So if you'll just reach down under your chin and feel that first real bump, what people would call the Adam's apple, for example. And I always thought it was interesting we call it an Adam's apple because, women have a thyroid cartilage too, and we don't call it an Eve's apple on women. And so you both, men and women, have a thyroid cartilage. It does tend to be more prominent in males, which is where I think the name Adam's apple comes from, because you can see it and feel it more in males. But even the women who are watching this, you should be able to reach down and feel your Adam's apple, or maybe we should call it your Eve's apple, and that's the thyroid cartilage. If you keep your finger on the thyroid cartilage and then you kind of just start to move down, the next hard thing that you feel will be the cricoid cartilage. And there's a space in between the thyroid cartilage and the cricoid cartilage, right in between those two. If that's the thyroid, the bump of the thyroid, you can't really feel the cricoid nearly as easily as you feel the thyroid cartilage, but it's basically the next ring of cartilage down from the thyroid cartilage. But there's kind of a space in between, and that space becomes important if somebody needs to have a tracheostomy, where we have to put a tube in their neck to help them breathe, because maybe their tongue is so swollen that we can't put a tube in from their mouth, or maybe they've been in a serious car accident, maybe a motorcycle accident, and they've got so much facial trauma and bleeding that we're not able to get a tube in through the mouth, then we will go ahead and put the tube in through the neck, and that's the location, is right in between the thyroid cartilage and the cricoid cartilage. So those are two new names that you need to learn. I would focus on the thyroid cartilage because that's the one that you can really palpate easily. When we have lab together next, you can, if you're not sure where the cricoid cartilage is, I can help you find that on your own neck or on your partner's neck. Okay, sternocleidomastoid has two heads, and we may see a better picture here in a minute, but you can kind of see a rise there and a little bit of a rise there, and that would be the clavicular head and the sternal head of the sternocleidomastoid muscle. So if we take a look from the side, these are no new terms for you in the head region. Parietal, temporal, and occipital region of the head, just follow those bones that you've already learned. Nuchal region is basically the neck. Think about where like a mama cat grabs her baby cats by the nape of the neck and carries them around. That's the nuchal region. I do want to introduce you to two triangles. You'll see there's an anterior cervical triangle. So remember, cervical means the upper part of the spine, right? The neck part of the spine. And a posterior cervical triangle. And what separates the anterior from the posterior is the sternocleidomastoid muscle. So if you turn your head to the side and kind of feel the belly and tendon of the sternocleidomastoid muscle, if you go anterior to that, you go forward to that, that's the anterior cervical triangle. And if you reach posterior behind that tendon, you will be in the posterior cervical triangle. And that becomes important just because when you're doing procedures on someone's neck, you want to know what underlying structures may be in that region. So if I'm in the anterior cervical region, for example, I know that the carotid artery is there, and so I'm going to have to be very careful of that. If I'm in the posterior cervical triangle, I'm going to be careful about the external jugular vein and something we call the brachial plexus, which we'll learn about in the nervous system. It's basically a network of large nerves that come out from the cervical spine. So you need to be careful if you're doing any procedures in that region that you don't accidentally hit the brachial plexus. So it's important to know where's the anterior cervical triangle and where's the posterior cervical triangle. And it's easy to identify by just looking anterior or posterior to the sternocleidomastoid muscle and tendon. This is just another view of this anterior and posterior triangle. And you can see again the dividing portion is the sternocleidomastoid muscle. Posterior triangle is this one here, and anterior triangle is this one here. That anterior triangle can be broken up even into more triangles, and I'm not really going to make you learn these different parts of the anterior triangle. I just want you to be aware that they exist, and they're basically broken up into what structures are in there. So for example, the ICT has the carotid in it, is the inferior portion with the carotid. SCT would be the superior portion with the carotid. Submandibular and subhyoid triangle, just based on what other structures are in that area. But if you can remember anterior, remember that it has the carotid artery. That's kind of the main structure there that you have to be worried about. And then the posterior triangle, remember that brachial plexus that's back there that you have to be worried about. I'm not sure we see a lot of other new things in this picture. You got the clavicle here. You can kind of see the acromion if you'll reach up from your clavicle and just kind of follow it along to your shoulder. The bump that occurs between the clavicle and the head of your humerus, that's the acromion. And in very thin people, you would actually be able to see that. That looks like about really all the new stuff. You can still see trapezius, of course. That's that big neck muscle. And the thyroid cartilage we talked about. Hyoid bone can't really be seen It can be felt above the thyroid cartilage, but it's really not able to be seen. Okay, if we move down to the thorax, I just wanted to kind of go through a case to help illustrate why it's important to know surface anatomy, how that's helpful clinically. So we'll talk about John. He's very tall and thin. He's 35 years old. He's a smoker. And he was out shopping for an engagement ring for his girlfriend, and he began to have difficulty breathing. He went to sit down because he was feeling poorly, and he suddenly collapses unconscious on the floor. And when you take a look at his chest, you notice that the left side of his chest appears to be bigger than the right side, and that it's also not moving in and out when he breathes like the right side is. You put your ear to his chest, and you can hear that air is moving on the right, but there's no air moving on the left side of the chest. And you believe that John has a pneumothorax. If you remember when we were talking about body cavities and we talked about the pleural space and the pleural lining to the lung, we had talked about a pneumothorax. If that lining gets punctured, how air can escape from the lungs and cause the lungs to collapse. So you suspect that John has a pneumothorax, a collapsed lung from being punctured somehow, and you want to relieve the pressure. You want to kind of get the air out of the chest cavity so that the lung can re-expand and begin to work. And the question is, where can you put a sterile needle to help relieve the pressure? And I always find this funny that every doctor show that I've ever watched has an episode where somebody is in an airport or in a restaurant and they kind of stick a tube in somebody's chest in order to relieve the pressure. So if that ever happens, there is kind of a better place where we should put the needle, and it's better if the needle is sterile, obviously, so that you don't get any infection. And so we're going to look at the chest, and we're going to identify some areas on the chest, and we'll talk about, just as an example, where you would put this needle in order to help remove the air from the chest cavity and remove pressure from the lungs. Okay, so if we're moving down from the neck and we go down to the chest, we still see, of course, trapezius, and you still see sternocleidomastoid. You still see acromion and clavicle. You can look at the sternum, and you could break it up into what would be manubrium, and then, of course, the body. And the xiphoid can be felt. Not usually seen unless it's a very thin person, but you should be able to feel the pointy end of the sternum, what's called the xiphoid. And that's an important landmark for when you're doing CPR, because you want to make sure that you're above that landmark so that you don't break it when you're doing chest compressions. If you're a little bit too low on your chest compressions, that bone has a tendency to get broken. So you want to make sure that you're kind of up here, more in between the nipple line than down over the xiphoid, just to help prevent a fracture there. We know the axilla, that's the term for armpit. We learned that previously. The deltoid, of course, is the big muscle that covers most of the shoulder. It's very superficial, so it's the muscle that can be seen, especially if this is a very kind of fit person. You can see it easily. Of course, pectoralis major, most of you already knew before even entering the course, is that superficial chest muscle that can be seen. We then have a nipple and an areola. So the nipple is the part that sticks out, and the areola is the darkened skin that surrounds the nipple. You can see biceps brachii very easily. You can see that cubital fossa, or we often call it the anti-cubital, meaning in front of the cubital part of the bone, fossa. The umbilicus, of course, we learned about, is another term for belly button. If you have someone taking a big breath and they're thin enough, you can actually see what we call the costal margin. Costal margin means the edge of the ribs, the bottom edge of the ribs, and they kind of look like that. You can certainly feel it on yourself, how they kind of come up to a point, and where they come up to a point, I should have drawn that xiphoid. Either I needed to draw this up or I needed to draw the xiphoid down, because where the ribs come together is basically where the xiphoid ends up being. We did talk about medial and lateral epicondyle, if you remember. So the medial epicondyle will be kind of the bony protuberance right at the elbow on the medial side, and there is similarly we'll see when we look at a posterior view, a lateral epicondyle. And here is the median cubital vein, just kind of distal to the antecubital fossa. It kind of runs through here, and that's where you will often try and place an IV, for example, in order to give IV fluids or give blood products or give medications, because it's a large superficial vein that's usually easy to find. So if we take a look at the chest, and we take a look at kind of how the sternum and the ribs would overlie the chest, you can see these red dots. These are the areas where we listen for heart sounds with a stethoscope. So I don't know if you've ever paid attention, but when a nurse or a doctor is listening with their stethoscope, we're not randomly placing our stethoscope on your chest. We're actually trying to place our stethoscope over these 4 areas. Here on the right side of the patient is this first one. I'm going to label that A, because that helps us hear, that's kind of the closest area to the aortic valve, so it helps us hear what's going on with the aortic valve. I'm going to label this one right on the other side of the sternum to the left, P, because that's where we listen for the pulmonary valve. I'm going to label this kind of lower dot next to the sternal edge on the left, T, because that is where we listen for the tricuspid valve. And then this last dot, which is in between the 5th and 6th rib and kind of just medial to the nipple, I'm going to call that M, because that's where we listen for the mitral valve. So we put our stethoscope in those 4 locations to help us hear what's happening at the 4 valves in the heart. And to help us remember it, we say that we listen at apartment M. And that helps us remember APTM, aortic, pulmonary, tricuspid, and mitral. So knowing those surface landmarks that you can feel with your fingers helps you know where to place your stethoscope. Similarly, we would place a stethoscope, if we go back to the case of our poor shopper who was shopping for his girlfriend's engagement ring. If you think about the fact that air rises, we want to certainly put our needle somewhere in the upper part of the chest in order to hopefully hit the pocket of air that is collapsing the lung. And so where we're going to go in order to be safe is we're going to hit, if we get too high, if we try putting a needle too high, there are some major blood vessels and nerves in that area, and so we try to avoid that. So what we want to do is the second intercostal space. So the intercostal space means the space in between the ribs. So first intercostal space would be the space in between the first rib and the second rib. So this would be the first. The second intercostal space would be between rib number 2 and rib number 3. So this is second intercostal space. And we want to go about the midclavicular line. That means we want to take a look at the clavicle, and we want to go about halfway down in that space, and that's where we would put our needle in order to relieve the pressure from, I think his name was Joe, from Joe's lungs. If we put a needle in there, the air will then escape through the open needle, and it will relieve pressure from the lungs. His lungs will re-expand, and he'll be able to breathe. Now, this is only a temporary measure because the air will eventually reaccumulate and that little needle won't be enough. So he's going to eventually need a chest tube, which we're going to put in the 5th intercostal space, 1, 2, 3, 4, 5. And we're going to go just lateral to the nipple. So we would put an incision here, and we would put a tube in there, and we would snake that tube up here, and we could attach this tube to suction, and then we could suck the air out and help the lung re-expand. Okay, if we take a look at the back, again, this would be in a pretty fit person. A lot of you guys are athletes, and you probably have some muscles like this that you could show. If we look at the back, we're going to see some of the same muscles, but largely different muscles than we were seeing at the top, right? And these aren't anything new. These are muscles that you've already memorized, so that's just showing you where they are on the body. So we'll start with biceps there, deltoid there, and triceps there. Those are pretty easy to identify. Trapezius is always easy to identify. It's got that kind of triangular part there. But remember that it's also, you can kind of see the outline of it here. Remember, it's a superficial muscle and it's quite big. Latissimus dorsi would be superficial and below that. You can also see, if you look closely, teres major in here. If you look over where the scapula is, you can kind of see the spine of the scapula, see this projection right here. So right below that would be infraspinatus, and right above that would be supraspinatus. And the iliac crest, I'll just point out, is kind of when you put your hands on your hips, you're putting them on the iliac crest. And that would also be visible from a lateral or posterior view. All right, if we look at the case of Elijah, we'll say he's 16 years old. He's very confused. He has a high fever, headache, and a stiff neck. After seeing him, you're worried that he might have meningitis, which is inflammation of the lining of the brain and spinal cord. It can be caused by a virus or a bacteria. The bacterial version is much more deadly and urgent. So the question is, how would you prove that Elijah has inflammation of the brain or spinal cord? How could you, what could you do on your exam, or what could you do with maybe a laboratory to figure out if he has meningitis? So we're going to go through and look at the back in a little bit more detail and see how that would help us figure out this clinical problem with Elijah. If we understand surface anatomy of the back, then we're going to be able to help get some more information about Elijah. So keep that in mind as we go through looking at the lower back. So if we look at the lower lumbar area, if you just kind of, touched your finger along the center of the back, you would feel these spinous processes sticking out. And that's how you would know where the spine is. So you can have somebody lean over a little bit, and you can feel those spinous processes. Remember also that you should be able to feel the iliac crests or the hips, the hip bones, and that's going to be another marker for you. So if we're talking about someone like Elijah, in order to prove that he has inflammation of the brain and spinal cord, we need to get a sample of the fluid that is in the spinal cord. It's called cerebrospinal fluid. And in order to get that, we have to stick a needle past his vertebrae and actually get into the space where the spinal cord is floating in the fluid. We want to be very careful when we do this because there is a potential that we could accidentally puncture the spinal cord if we put the needle in too high or too quickly. And if we go too low, we may be beyond the space that we need. So we want to kind of hit this sweet spot. As the spinal cord comes down, at about L1, it begins to thin because it sends lots of nerves out. And so it begins to get thinner and begins to separate into separate nerves. We call that the cauda equina. We'll talk about that when we get to the nervous system. So that means below L1, you've got kind of spaghetti-like, strings of spinal cord. And if you go above L1, you have a very solid spinal cord. So we certainly don't want to introduce a needle where the solid portion of the spinal cord is. That could cause serious damage. And if you get down like to L4, L5, that the spinal cavity pretty much ends there, and so you would get what we call a dry tap. You would actually not get in the space that you want. So basically we want to identify that space in order to introduce the needle to get our fluid. So the way that we find that is by understanding surface anatomy. So if we put our hands on the patient's iliac crests, kind of feel where their hips are, and then we kind of come straight over from there, we're going to find the space between L2 and L3. And that's an acceptable area to try and get your fluid. We could also go down one vertebrae by feeling the spinous processes, and we could go in between L3 and L4 and try to put our needle in that space. So those are the two areas that we want to try to put our needle in order to get the fluid that we want. But you're not going to be able to identify those those openings unless you understand the relationship between the iliac crests and the spinous processes of the lumbar vertebrae. So surface anatomy is used all the time to help us in procedures, to help us understand what anatomy is under that part of the body. It's very important. All right, let's move down to the abdomen. Again, not a lot of new things. We're just going to point out things that you should be able to see. Remember, you got that costal margin going up to the xiphoid process, and you've got pectoralis there. You can see serratus anterior kind of coming out like that on both sides. You can see the umbilicus again, of course. You can see the rectus abdominis. This is what people would call a six-pack or an eight-pack if you're very fit. You can kind of see that they're broken up into like rectangular muscles, right? So that's rectus abdominis. On the hip bones, you can identify the anterior superior iliac spine. You can see external obliques. The lines in between the rectus abdominis we call the tendinous inscriptions of the rectus abdominis. So you can see those. Pubic symphysis, you could feel if you palpated very low in the pelvis, you'd be able to feel the center where the two pubic bones come together at the pubic symphysis. You should be able to at least palpate that, if not see it. And then there's something called the inguinal ligament. Now, you're not going to see this or feel this, but you should just know that the inguinal ligament goes from the anterior superior iliac spine over to the pubic symphysis area. And that's an important dividing line between kind of the pelvis and what lies below. It's going to help you identify the femoral artery, vein, and nerve later on. So just some more views. You're seeing serratus anterior well there. You're seeing that costal margin where the ribs kind of end. Rectus abdominis again, those rectangular type of muscles. Linea alba would be a slight depression that goes right down the center in between the right and left rectus abdominis muscles, and you can see external oblique a little bit better here too. Yeah, nothing else really new there. If we take a look at the arm, we've already identified deltoid. We've identified triceps, which is going to be posterior, biceps, which is anterior. But here on the lateral view, you can see just a tiny bit of brachialis trying to peek out from underneath of biceps. What is actually more visible is brachioradialis. That's that usually prominent muscle, especially in people who play sports that have a grip. So, for example, if you play tennis or you play lacrosse or something where you're doing a lot of gripping, you'll have a very well-developed brachioradialis, and you can see it best right there on the lateral view. Now, of course, it extends down farther, but the majority of the belly of the muscle is seen right there in that area. We can now see the lateral epicondyle. Remember, on the anterior view, we saw the medial epicondyle. On this kind of posterior view, you're going to be able to see the lateral and feel the lateral epicondyle better. The olecranon, which is just the pointy part of the elbow. Just distal to the olecranon is Calcaneus, another muscle that you've already learned. And if you have someone extend their fingers, you'll be able to see the tendons of extensor digitorum, and you might see flexion of the belly of the muscle in that area as well. All right, so we're just showing you more of the same here, and I'll kind of let you look this one over on your own. We're not showing a lot of new structures here. We've already talked about most of these. You can see some of the extensor muscles as well. I'm not going to ask you to identify those on a picture, but you can be aware that you can see some flexor and extensor muscles as well down here in the forearm. Anteriorly, again, not showing you a lot of new things. You can see a lot of the muscles that you've learned. They're throwing in some of the veins, which we haven't learned yet. Don't worry about those. Just showing you some of the same muscles Now, I will say that when you make a fist, like they're having this man do here, and you look down towards your wrist, you've all noticed this kind of central bulging. That's the tendon of flexor carpi radialis. I will expect you to be able to identify that. It's a nice landmark to know where you palpate the radial artery, where you do some injections, is finding that that tendon of the flexor carpi radialis. And for site of palpation of the radial pulse, you're going to go radial, or you could say lateral, to that tendon. And that's where you're going to find the radial pulse that we check so often. So make sure, and I would just practice that on yourself or even grab a friend. Make a fist, find that kind of central tendon, and then go to the radial side of that. Relax your fist again and see if you can feel the radial pulse. I usually use 2 fingers so that I can kind of span a greater area on the radial side of that tendon. So make sure you can identify that. That could be a potential test question. I'm just showing this for the nurses who, we were talking about that common site where you would put an IV or you would draw blood in the antecubital fossa. There are less nerves kind of in this central area, and there's larger veins that are closer to the surface. So that's kind of a common place where we like to stick a needle. Let's take a look down at the lower extremities with the pelvis and the thigh. First of all, you'll just notice a lot of the muscles that you've been learning that you should be able to see on the surface of someone, you know, who's fairly fit. I mean, if there's a lot of adipose tissue covering the muscles, then you're not going to see this kind of definition. But let's say you have an athlete or somebody who stays pretty fit. You should be able to see sartorius kind of running at an angle across the anterior thigh. You can see rectus femoris, which will be kind of in the middle of the upper thigh. You should be able to see well vastus medialis. And then there's also vastus lateralis, which kind of is going to be a continuation from tensor fasciae latae here, and then you'll start to see vastus lateralis. I think we'll see this on another picture that's a little bit more anterior. This is kind of a medial oblique view, so you get some of the anterior muscles as well as some of the medial muscles. Gracilis would be in this area, but I don't know. I can't really see it in the picture, so I wouldn't worry too much about it. And then adductor longus will be in that area as well. Something that is new on this picture that I do want you to kind of learn is this idea of a femoral triangle. So just like we had that cervical triangle, we had an anterior and a posterior. Here we have just a femoral triangle, no anterior and posterior, just one triangle. But it becomes really important because it's where you're going to find the femoral artery, vein, and nerve, and these are important clinical structures. So the inguinal ligament is going to go from that anterior superior iliac spine down to the pubic symphysis. So that's going to form kind of the superior edge of that triangle. And then sartorius will form the lateral edge. And then the edge of adductor longus will kind of form the medial edge. So in that area, you're going to have femoral nerve, artery, and vein. So for example, you'll feel for a femoral pulse in that area. You might do blood draws from that area, from the femoral vein if necessary. Tibial tuberosity and patella are also able to be seen on the surface anatomy of the leg. Here's just kind of a inside look at that femoral triangle that I was talking about. And you can see that it's, if you go from lateral here to medial here, it goes in the order of nerve, artery, vein. And one of the ways that we remember that is we think of the word navel. Sorry, that L got moved over. Which is the other word for belly button, but that helps you remember N is for nerve, A is for artery, V is for vein, E means empty space, and L is lymphatics. we don't really worry too much about the empty space for the lymphatics, but it helps me remember anyway that going from lateral to medial, the order is nerve, artery, vein. So this is important, for example, if I want to put a central line into the femoral vein, which is a very large vein and easily accessible because it's close to the surface. When I go to feel a pulse, what I feel is the femoral artery right here. So I don't want to put my central line in that artery, I want to put it in the vein. So how do I know where the vein is in relationship to the pulse that I'm feeling in the groin? Well, I know that it's going to be medial to the pulse. So if I put my fingers here and palpate the pulse, I know to put my needle medial to that, and I should hit the vein. If I go lateral to that, I'm going to hit the nerve and cause quite a bit of pain, could cause some damage, and of course will not be able to get the blood access that I need. Okay, so this is showing you more of a lateral view of the thigh and part of the knee. So you have that tensor fasciae latae comes down and joins what we call the iliotibial tract. And then just medial to that, you'll see vastus lateralis in here. And then this would be rectus femoris out here. Now that we're seeing part of the hamstring muscles, remember we're looking kind of more at a lateral view. So laterally you're going to have semitendinosus and underneath semimembranosus. If you're looking more medial, you'll see biceps femoris. Here is the tendon for biceps femoris. You can see gastrocnemius, which we call our calf muscle. Soleus is kind of tucked away in there. That's a little bit harder to see. Fibularis longus you can see here. There's the patella and the tibial tuberosity once again. Remember that popliteal fossa we talked about in the very first lecture that we did when we were looking at different regions of the body? That's kind of like the knee pit. So you can see that there as well. Now if we kind of look directly posterior, the main things we're going to see obviously are the gluteus maximus, because those are easy to see. You could palpate, usually you can't see, but if you touch just lateral there, you can usually find the greater trochanter of the femur, and that's a good landmark. We call these the gluteal folds here. Often you're doing an injection, you nurses will learn kind of if you cut the buttock into 4 regions, we say you want to go upper and outer, and you're going to kind of do some injections in that area. So that's good landmarks to know as well. Iliac crest again would be kind of the hip, the top of the hip bones there. Your hamstrings are going to be in here. Hard to distinguish individual hamstrings. Popliteal fossa again, that's where you're going to find the popliteal artery. To check a pulse, you can check a pulse there as well. I wouldn't worry too much about the tendons of the different muscles. I'm not too worried about those as long as you can identify hamstring muscles here, gluteus maximus, popliteal fossa, where you can find the popliteal artery and feel a pulse. If you go down lower, of course you've got the patella in here. You've got a ligament that connects the patella to the tibia. Now that we're looking at the lower leg, we can start to see some of the vastus muscles, some of the quadricep muscles a bit easier. So vastus lateralis is going to be this muscle on the outside. Rectus is going to be kind of in the middle. And you can see vastus medialis again on that medial aspect just above the knee. Should be easy to identify in most people. This area here. Okay, then that tibial tuberosity again, just below the patellar ligament where it inserts. What other ones? You can see gastrocnemius, the calf muscle still. You can see fibularis longus, and you know that that's fibularis longus because it's on the fibular side. Remember, the fibula is always on the lateral side of the foot, or the pinky side of the foot. So there's your fibularis longus. Tibialis anterior takes up really most of the shin. It's what covers that tibia bone. and soleus would be tucked away in there, kind of deep to gastrocnemius, hard to see. I do want you to remember the lateral and the medial malleolus, and this is where you would check a pulse, is just kind of lateral, or I should say posterior to the medial malleolus. You can feel a tibialis anterior pulse. We'll talk more about that when we get to the cardiovascular system. For now, just remember lateral malleolus and medial malleolus. Make sure you can identify tibialis anterior, gastrocnemius. This is going to be better seen on a posterior view. The tibial tuberosity we've seen a few times, patellar ligament, patella, and make sure you can identify vastus lateralis, medialis, and rectus femoris in the middle. Okay, this is giving us a posterior view of the leg now, and you can see the hamstring muscles in the back. Biceps femoris is going to be the one that's kind of easiest to see here in the middle. Semitendinous will be kind of next to that, and membranosus will be kind of a little bit deep to those. You can see the input of gracilis, sartorius. There's that popliteal fossa again, where you can palpate the popliteal artery for a pulse. Gastrocnemius is now easy to see with both the lateral heads and the medial heads. Soleus is kind of a little bit deep to that. Make sure you can identify the calcaneal tendon, which we call the Achilles tendon, right? Make sure you can identify that. We've got lateral and medial malleolus again. Calcaneus is where the heel is. So not really anything new here. Medial and lateral malleolus and calcaneal tendon, or the Achilles tendon. There's not really too much else there that you have to worry about. We will talk about the dorsalis pedis pulse when we get to the circulatory system, and that's going to be kind of in this area on the dorsum of the foot. There's an artery that comes close enough to the surface that you can feel it for a pulse as well. Okay, just a quick word on cross-sectional anatomy. I think it's just, we talked about this, we looked at kind of cross-sectional drawings earlier in the semester. I wanted to just show some pictures of what this looks like in the human body, and now that you've learned some parts of the human body, it may make a little more sense to you. So if we did like a transverse section of the head, for example, and this is anterior here and posterior here, you can see obviously the brain inside, and you'll learn several parts of that brain coming up in one of the next units. You can see the optic nerves coming and crisscrossing. If you remember that the sella turcica and the optic canals in the sphenoid bone, that's where those optic nerves crisscross. You can see some of the ethmoid air cells in here. Of course, the nasal bone, the eyes, parietal bone, occipital bone. These are some of the things that you've already learned. I don't think I'm going to give you any pictures of these. I just wanted to go, on your exam, I just wanted to go over these so you can just start getting used to seeing cross-sections of the body, because when we look at MRIs and CTs, this is pretty much what we're looking at, just in a different form. And of course, you don't know the hypothalamus yet, and hippocampus and all that. We'll learn that when we get to the nervous system. But you can see the parts of the bone that you know. That's kind of a gross anatomy cross-section. So if we go from typically looking at our CT scans, and so you can see again the eyeballs here, you can see the optic nerves coming back. So you know that this is going to be like sphenoid here. Pituitary is going to be in that area because it sits in the sella turcica of the sphenoid bone. You can see some subcutaneous tissue here showing up white. That's basically skin and fat, subcutaneous fat. then the muscle looks kind of gray on either side. So you learn muscles like temporoparietalis and temporalis. This is probably temporalis deep and temporoparietalis above that. And then several structures in the brain can be seen that we'll talk about when we get to the nervous system. But this would be a transverse section through the brain at the level of the eyes. We could also look at the level of the chest, and this would be at T8, thoracic vertebrae 8. And you see if we took a section through there, we'd expect to see heart, lungs, maybe some blood vessels like aorta, esophagus. Trachea is probably already bifurcated. Trachea usually splits up here, so you probably won't see trachea. So let's take a look and see what we can see here. If we take a slice through there and kind of turn it on end so we can see, remembering that anterior is here and posterior is here. We can see the two lungs right here and here. So this would be right lung here, this would be left lung here. So what is in between the lungs? This is the heart. And you can even see different ventricles, left ventricle. On this side with its thick muscle, we'll talk about in the cardiovascular system. You can see back here, you guys learned about vertebrae. So there's a thoracic vertebrae, looks just like you guys have learned. Esophagus is in there, thoracic aorta is in there, and the mediastinum like we learned before. But you can also see several of the muscles that you guys have learned. So, for example, you can see latissimus dorsi. You can see the ribs that you guys have been learning. You can see some of the like pectoralis muscle. Here's pectoralis major out here on the anterior chest. So you can not only see the organs, but you can also see the bones and the muscles as well. So if we took that same view and we got a CT scan, which is what we see here, air always looks black on a CT or an X-ray. So you see that black is going to be where air is, so that must be the lungs. This is the right lung, this is the left lung. And of course, in between again is the heart. There's that nice thoracic vertebrae that you can see with its transverse processes, its spinous process, its body, and then the canal here, the foramen that the spinal cord actually runs through. You can see all that very nicely on a CT. You can also see pectoralis major here out front, latissimus dorsi on the back side, like we saw before. You can see the aorta here that runs posterior. So anyway, so we're gonna start seeing these pictures as we go through and we learn about, for example, cardiovascular system and respiratory system. We'll start seeing some more pictures like this, either in cross section or maybe a coronal section. So make sure for your exam from this lecture that you really focus on the surface anatomy part. And we did learn a few new areas like the anterior and posterior cervical triangle and what structures were in those triangles. For example, we learned about the inguinal triangle or the femoral triangle as well, the inguinal ligament. Those were a few new ones, but mostly it's just learning to identify bones and parts of bones and muscles that you've already learned, just be able to identify them from pictures like you see here in this lecture. I'll put the PowerPoint up so you'll have access to those pictures as well.